Great. All right. I have a feeling a few more people will trickle on, but I want to make sure Helen has the full hour. So let's just get started. So I think everybody knows Helen. If Helen, if you wanted to just start with a quick introduction of your specific role at Bi-State, but I think since this is mostly just our health cross-cutting team, I think everybody knows Helen, and I just want to start by saying thank you for doing this. And, just a reminder that this webinar was intended because we're planning that panel for the spring where we'll have different players from the healthcare systems world. And so just for us to have a little bit of a background of healthcare reform, what that means, just so we're kind of going into it a little bit better informed, in case the panelists are expecting us to have a little bit of understanding. So that was kind of where this conversation started, and Helen graciously volunteered to do this because she definitely understands this world a lot better than I do. So I'm going to turn it over to you, Helen. Thanks so much.
Great. Well, thanks for giving me a chance to do this talk. And so I'm Helen Laban. I'm the Vermont Public Policy Director at Bi-State Primary Care Association. And we represent the federally qualified health centers, as long as we also have membership from the free clinics and the Planned Parenthood clinics in Northern New England, and the AHECs, the Area Health Education Centers, which work on workforce issues in healthcare. But basically, we represent folks who are providing primary and preventive care. One of the things that the policy director, so every state has the equivalent of a primary care association. And one of the things that we are paid to do and also required to do by the federal government is to do education around value-based care models, which is a fancy word for what Vermont's doing in healthcare reform. So I've got a presentation that I modified that I've done for healthcare providers in the past. We'll see how it goes with a non-healthcare provider group that does sort of an overview of healthcare reform, value-based care, and then accountable care organizations, the all-payer model, a little bit about what the Green Mountain Care Board are, some key players when you talk about the healthcare system in Vermont and who will be participating in that panel. And one thing to note that I think is understood when I talk to people who are doing healthcare but may not be broadly understood, when I talk about an accountable care organization or an ACO, that's a particular structure that exists throughout the country. I'll talk about why Vermont's is unique. Right now, One Care Vermont is our ACO. So I'm going to be talking about the structure of an ACO, but if you want to, it's like saying facial tissue versus Kleenex. So our brand name of ACO right now is One Care Vermont. But I'm going to be talking most of it about the broader term of an accountable care organization or ACO. So that just that one point of clarification. And I think I've got a slide deck that I'm going to do that I'll also make available with notes. And unfortunately, I think the only way to do this really is to do it college lecture style. So, because it's a lot of information, probably it requires checking the slide deck. What I'm going to do is, it is a presentation where, because it will be available later, I can, if we run out of time, I can just wrap it up and then be available to answer questions. So what I'll do is I'll set myself a timer so that I know when I have like 10 minutes left, and I'll wrap it up then. So if you hear a timer go off, it's because I'm about to set one. But otherwise, I'll just go through the slide deck, and folks can fill in with questions at the end, or also, of course, you know where I am. So you can just ask me later. And like I said, I'll make the materials available. So let me see if I can do the share screen, pull up my nifty PowerPoint. You're going to learn that my PowerPoint creation skills are really lackluster. These are not pretty, but they get the point across. All right, so hopefully everyone can see that. And I'll get started. So as I said, this is what we're going over, healthcare reform, what we mean when we say that, value-based care, the ACO, all-payer model, Green Mountain Care Board. So we're going to start from a point of national consensus. There is a point of national consensus. We want better health, and we want it to cost less money. So this is as simple as it gets right now. And this is the ultimate goal of healthcare reform. And now just to add a little bit more to what that means. So in the US, we're really good at treating individual treatments, including for rare and complicated diseases. We definitely don't want to lose that, but we're not doing great across a range of measures, one of which would be life expectancy, so like the biggest measure there is. But also you can see, for example, this chart to the right is showing the increase in folks who have chronic conditions and multiple chronic conditions. So that's a measure for not only our individual people not necessarily having the best quality of health, but also whole populations do not have the best quality of health in the US. And this is I really love this chart. I stole it from somebody else. It's from the World Bank, and this is showing a couple of different things at once. It's showing that life expectancy versus health expenditure over time. So the US is spending way more than everyone else without necessarily having as great a gains in life expectancy. So we've got low life expectancy. We also have not great health during that shorter lifetime. And I should say Vermont is, we do pretty well in terms of health, but actually we had historically been spending even more than the national average. So our spending was going up faster than anywhere, than the rest of the country. So not only were we not doing great as a country, we weren't necessarily doing great in Vermont. And this is a slide showing that. This is from the Rural Health Services Task Force report, which is available online and is a good overview of some of the weaknesses in the system. So this is where we begin to get more specific into the particular model that we're talking about today, which is going to be the ACO. So something to note, when we talk about we want better health for lower cost, we have a very specific meaning for lower cost. What we mean is that we are going to contain the growth of healthcare spending benchmarked to the overall economy. So it's not going to rise faster than the overall economic growth, which at the time that we started the contract for our current model was 3.5%. So you hear that used a lot. That's really a simplified way of saying that it's tracked to GDP. The other particularly important thing to note is that for the context of what we're talking about right now, we are not including the price of pharmaceuticals. And that's a big issue. So when you looked at the commercial insurers' rate increase requests that happened last year, last year, 2019, the largest driver of that increase was the increase in costs of pharmaceuticals. And that is certainly an issue that people are looking at. There's a question of what states can do. So the fact that we're dropping this from our calculations doesn't mean that nobody's working on it and nobody cares. It's just that that's not what this particular model that we're talking about today is designed to address, partially because it's unclear what states can do on their own or if it has to be a federal fix. This model in healthcare reform that we're talking about today does indirectly get to the issue of pharmaceutical spending, because if you have better health, then you don't need as many drugs. And so in that sense, it would save, and we'll show how that plays out in a couple of slides. But just to note that when we talk about lower cost, it's really a somewhat narrow definition of lower cost. Okay, so if we've got this goal of better health for lower costs, sort of the simplest way of phrasing the strategy that we're pursuing is to invest further upstream in primary care and prevention. So that means that you're investing in keeping people well, and that also means that you're taking responsibility for the health of your entire population, not just people who are already sick. So that's the broad strategy that we're following here. But that comes with complications, right? People who are not sick usually don't like going to the doctor. So already you're implying that there's going to be new partners and strategies for healthcare beyond the doctor's office. You also can't prevent anything, and this is a big deal. And if we were doing a presentation on healthcare financing and payment reform only, we would pretty much stop now and spend the rest of the time talking about this issue. So, you know, I can be the healthiest person around, I can do everything right, and I can still hit black ice when I'm driving home tonight and need some expensive medical care, right? So as you structure the payment system and how we're going to fund healthcare, you need to manage for that fact that there's going to be outliers, there's going to be expensive treatment needed, and that is a big part of what actuaries are doing and what people who are building the contracts in healthcare are doing. So another issue, and this is particularly germane to folks who are working on things like investing in healthy food and diet, is that the idea is to contain the growth of spending. So as we build new approaches and we try not to lose what's valuable in the old approach, we also need to do that somehow while containing the cost of healthcare. So that's a significant challenge. And that's as simple as the strategy gets. So it's already not all that simple. Another important point is that when we talk about healthcare reform, and this is something that often confuses people, we're not talking about just one thing. We're really talking about three different types of reform in broad categories. We're talking about payment reform, which is how the dollars move around the system. We talk about payer reform, which is the level of who's injecting dollars into the system. So, you know, the most famous example of this right now would be Medicare for All, right? That would be a payer reform. And then delivery system reform, which is change in how the care is provided within our communities. Sometimes you hear it referred to as practice transformation, which is sort of a subset of delivery system reform. That's changing what's happening at the healthcare practices. But because this model includes a broad range of community partners, it's not just at the healthcare practices. That's a subset of the broader category of delivery system reform, which you will occasionally see acronymed as DSR. And all these things need to happen, and they all need to be attacked at once. I think a lot of political conversation is around the payer reform section of things, but even if you have the most brilliant payer system ever, if they're injecting money into a system that then doesn't work very well, you haven't actually solved the problem. So we'll be talking about payment reform, payer reform, and delivery system reform. And I'm going to start with payment reform and then show how the others kind of build in. So payment reform right now, or I should say the starting point, because we have changed things, is fee for service, which is providers are getting paid for doing stuff. And you'll see there's books and books of maybe literally a million specific codes that document exactly what you did in a visit, and you get paid based on those codes. So sometimes this is called volume-based, and the idea is that if you're paying providers for intervening, for having lots of visits, for doing lots of tests, for prescribing lots of pharmaceuticals, then you're not necessarily incentivizing what we want. So, and this is basic economics. So the example here is if your website is getting paid by the click, then you see what we often see if you look at the clickbait links at the bottom of a web page. They have a gallery of pictures and you have to click to see each picture in a row. The reason why it's set up like that is that those websites are being paid by the click, and they're responding exactly to what that incentive is by having an annoying structure. So we want to get away from this. And the way we get away from this is moving towards value-based payments. And there's a variety of different models for what we call value-based payment, but the idea is getting back to that original goal. We're going to pay healthcare providers for keeping people well and keeping whole communities well. And the most advanced version of this is something called a global budget, where providers are paid a predetermined amount to keep their community well. And there is a lot of, many economists and actuaries are kept very happy figuring out what that appropriate budget is. There's a lot of work in that area for those who want to dig in, but that's the general idea. Is I have a set amount of what it should cost to keep the people in my community well, and I can spend that in whatever way best matches the needs of my community. I should say, and I should say two things. One is that's the most advanced, and we're about to see that there's different intermediary steps from fee for service to that global budget system. It's also important to note that here we're talking about payment for the services. You also need dollars to invest in setting up those new systems, as we already mentioned. So when you see a detailed discussion of, say, a global budgeting system, it does include money for that as well. So here's an example of what we mean when we say that different payment models address different approaches to care. So right now we have, say we have a fee-for-service situation where we have a patient with uncontrolled type 2 diabetes. They have an ER visit plus an inpatient stay. That's very expensive. The patient is not happy. The payers are not happy. That's what we want to avoid. So taking that back upstream, we could invest more at the primary care provider, acronym PCP, primary care provider, where they're tracking that type 2 diabetes, they're using insulin to manage it, there's regular check-ins with that primary care provider. That's better for the patient. It is less expensive for the system. It's a managed situation. You could go further upstream and say, all right, before we get to the point where we need the pharmaceutical treatment, maybe there's a visit with a primary care provider. You see that the blood glucose levels aren't where you want it to be. There's a risk of type 2 diabetes. You caught it early. There's nutrition counseling. There's remote patient monitoring of glucose levels. You may or may not need a pharmaceutical intervention to control this. Or you could go even further upstream, starting at the very beginning with the community-based prevention, where you're investing in food security, you're investing in cooking groups, local farm connections, a healthy diet, lifestyle that supports not developing any of these markers of concern for type 2 diabetes. So that community-based prevention is the best solution, right, for everybody, payers, individuals, the universe. That's where we want to go. And we can map this onto the different payment systems. So fee for service is tied to services at medical offices and pharmaceutical purchases. If you go to an alternative payment model, so moving towards that value-based care, you can bring in other types of services at other locations, for example, the home monitoring. You can begin to get more creative in treatment. And then a global budget would allow for investment in what keeps people healthy. And so those two can map together. This is the more formalized way of saying that example that I just did. Don't worry too much about the chart to the right, except for just know that this is a famous chart for those who are really into healthcare payment reform. This is a famous chart. It's called the HCP LAN APM framework, which just shows you what sorts of things we get excited about. But the overall, this is showing, like I said at the beginning, there's the fee for service, which is that orange category. And then there's a bunch of different ways to do that value-based payment. And the idea is that you don't flip a switch and go from fee for service to the most advanced payment system, that it's a journey through the different categories towards global budgets. Another important thing to note is that this framework, as I've described it, but just bears reiterating, is not built on limiting access to care, right? The premise on of how we're going to save money isn't that we're going to limit people's access to care. It's that we're going to change the type of care that's being delivered. We're going to deliver better care, and we're going to deliver it earlier, before people get sick or at the early stages of illness, not wait until a crisis situation. And in Vermont, and this point number 5 is one that if we were all healthcare providers, we would spend a lot more time on, because it is a business problem right now in Vermont, and everywhere. I mean, it's just an unfortunate function of the system, is that not all payers, which we'll get to later, and not all providers are at the same point on this journey towards different payment structures for various complicated reasons. So if you're operating a community healthcare center, you may be receiving different types of payments from Medicaid than you are receiving from your commercial payers. So you're being paid in different ways by 2 different sources of income, but you need to deliver the same quality of care to all patients regardless of who's paying the bills. And this is a financial problem right now, in the world of healthcare reform. So you hear, on one hand, people are anxious about the risks of fully transforming the system of delivering care and paying for care. On the other hand, they certainly don't enjoy hanging out in this middle distance where there's different payers paying in different ways and you're running different books of business, but delivering the same quality of care for all patients. So that's an issue that you hear talked about a lot in healthcare reform conversations. So so that's like the short version of payment reform, moving from fee-for-service to value-based. So if you take that progression that we just did with payment reform, you can also see how it supports change, but it's not sufficient to change, right? So you can ask questions like, is there coordination across all these different levels, from the community-based groups through the primary care providers to the hospital system? Do you need technical assistance for those providers? For example, if they're doing that remote patient monitoring for glucose, do they need training on how to implement those systems? If we move into community-based prevention, which is not in the healthcare model of how you trial interventions and test them for efficacy, how do we then know what interventions are going to make the biggest difference in health, which is an ongoing question that researchers have grappled with for generations. So we've got research questions. And then, are the people who are funding this communicating? So if USDA is working on food-based programs, are they communicating with CMS, which is the federal folks who are funding Medicaid and Medicare? Are they coordinating? We don't know. And these issues are going to be dealt with in the spheres of delivery system reform and payer reform. So you need to have all of these different components coming together. So in summary of this component, we want our healthcare providers to keep individuals and communities well, and that's helping towards our big goal of that better healthcare and lower costs. Getting there is going to require payment reform, so aligning the payment system with with that big goal of how we want healthcare delivered. Delivery system reform, which is changing what actually happens in our communities, which is supported by payment reform, but that doesn't take care of it on its own. And then that payer reform of everyone who's putting money into the system being on board with these changes. And we'll talk a bit more about how that payer reform component comes into play in Vermont. So to do all this work, we then have a structure of the all-payer model, which is that payer reform piece, and that is supporting an accountable care organization, which is doing the payment reform and the delivery system reform pieces. And we'll go next into how that gets set up in Vermont specifically. How am I doing for time? Oh, it's only 9:30. So I can pause if anyone has any questions before I go on to how this then plays out on the ground in Vermont. I realize this lot was just covered in a short amount of time.
Helen, this is Ashwini. I have a quick question.
Yep.
So you had mentioned the contracts. Could you just like do a quick explanation in terms of who's the contract with? Like, does the state government have a contract, for example, with OneCare, and then OneCare has a contract with the individual hospitals, et cetera? Like, what is the contractual relationship?
That's actually exactly what the second half does. So I'm going to pause that.
Yeah, that's great.
And any other clarification questions before I go into the long answer to Ashwini's question? All right, we'll just dive into that. So sorry, I've got to rearrange things on my screen here. Here we go. All right, so first, before we get into how the contracts are structured, just a quick, well, actually this is the background to how the contracts are structured. This is payer coordination. So just a quick, very short, this is how payments works in Vermont. So we spend about $6 billion on healthcare in Vermont, right? And the Green Mountain Care Board, it will be in the links, does a very elaborate breakdown of where the money flows every year. And there's a great report on that. But important for what we're saying right now is this pie chart that shows of the healthcare spending, who's doing that spending. And so the federal government controls Medicare entirely and more or less controls Medicaid. That's both state dollars and federal dollars. There's a matching system. The federal government pays a little bit more than half. And then other government spending, when you add that up, a little bit more than half of our money is controlled in some way by the federal government. So even if Vermont had like the most brilliant idea for how we wanted to restructure our healthcare spending, if we don't have the federal government on board, unless we have $3 billion hanging around to fill in the gap, we can't do it. So there's a fair amount of conversation with the federal government. Also, a side note, just so that no one gets confused by this graph, that out-of-pocket expenses, that's not the same as the uninsured rate. People get confused by this. Our uninsured rate is a little under 3%. It includes all copays and deductibles and everything else. So we need to coordinate with the federal government at a bare minimum to make changes. We also need to coordinate, though, with the commercial payers. Vermont, so when you see this ACO structure happening in other states, it's often for a particular payer or a small pocket of the population. But Vermont doesn't have very many people, right? And this is at its heart an insurance market, which means you have to manage risk. And so the smaller your pool, the bigger a problem that becomes. So when I go and talk to my colleagues in other states, they'll say, oh, I run an FQHC network, which is really small. It's super rural. We only have 500,000 patients. And I say, well, in Vermont, that's almost our entire population. So it's typical for modest-sized hospitals to have 1 million patients, right? So for Vermont, when we say in Vermont to get to scale with any of these payments and to be able to manage that risk and also have the majority of your patients covered in the same payment model, we're talking about basically getting the entire population together, which is a unique challenge that we face because we have that combination of having a small population, but also being super ambitious in how we want to reform healthcare. So we need a somewhat special model. And so when we talk about the ACO, we talk about putting together an all-payer model where the different payers agree to participate. All right, so then what is the ACO? So we want to work with the federal government to be more flexible in how we spend their money, to be able to make innovative investments, to do that further upstream investing. And fortunately, the federal government has a way to do that. It's called an accountable care organization. And to be specific, a next generation ACO. that gets back to that chart from a couple of slides ago where you saw there were different points in value-based care. So the one that's heading out towards global budgets, the most advanced one, is called a next generation ACO. And for our purposes, there's 4 basic functions that an ACO will do. One is care coordination. And so this is bringing all the different provider organizations together to coordinate around a patient's care. If you stay in a hospital, it's nice to think that then your primary care provider coordinates with that hospital after discharge. That doesn't necessarily always happen, right? So that's a very specific example of it, but it also gets into the area of patients with complex needs that includes non-medical providers. For our purposes, the question of after you've left that hospital and maybe you got connected to your primary care provider, do you then have the appropriate nutrition and meals that you need to recover, for example? So the ACO helps with that care coordination. And that's both a bringing people together and facilitating how they talk, and also some really technical things like how do we share the medical records. Data and analytics to support quality. So that's looking at, say, I think I'm a healthcare provider. I'm doing my work. I'm seeing as many patients as I can. And I don't know that, for example, my rates of smoking are much higher than everyone else in my community. But if you have a organization like an ACO that's taking a broader look at this, they can say, hey, Helen's practice, we can't help but notice that your patients show much higher smoking rates. Would you like to work with some providers who've had better luck in bringing down those rates, and they can support you in reaching the kind of quality you want? Practice transformation. So that's that whole thing that we talked about, that you can't just change the payment models. You also need to support providers in doing things differently on the ground. And then alternative payment systems, that's that payment reform that we talked about. That's moving everything towards those value-based payments in the global budgets. So those are the basic things that an ACO is formed to do. And this slide is an important one because some of this, we talk about it in the sort of fuzzy terms of all these things that can be accomplished, and it sounds like, well, couldn't just a bunch of folks in the room together do that? Why do we need this additional structure? And there's some things that are particular to this legal structure of an ACO. You're getting waivers from some federal regulations, from actually a lot of federal regulations. So an example of this is that if you wanted to do telehealth and be paid by Medicare, you have to be in a rural location normally. Well, in Vermont, Alberg is considered an urban location because of weird glitches in how the federal system works. Richford was considered a rural, urban location. So we can get out of those types of federal rules by going through an ACO. And you can negotiate additional ones as well, those special waivers. Waivers and prior authorizations, that's something that a provider cares a lot about. We don't need to go into detail on that. Access to clinical data for analysis, that has to do with the laws regarding who gets to see clinical data. The ability to coordinate payments across different organization types legally. So there's stark anti-kickback and antitrust laws that prevent, say, I'm a hospital and I want to invest in community health centers, FQHCs, because I care about prevention and I think they're doing great work. There is some small charitable investment that can be done, but generally speaking, you can't do that because it's seen as buying patients. So it would be seen federally as bribing that community health center to make you their hospital of interest if they need to refer a patient somewhere. So by being in an ACO, you get around that problem. And then also, as the federal government tries to move everyone towards value-based care, they do tie some funding pools to participation in an ACO. So for example, Medicare dollars that go towards our Blueprint for Health are tied to having an ACO in place. And then, like we said, the ability to enter into alternative payment contracts. And then there are also things that other structures could deliver but the ACO does as well. So just the advantages of being in a collaborative network, of sharing systems for efficiency, of pursuing a collective impact model for making change across Vermont. So these are the types of tools that our ACO is trying to combine. So again, this is just reiterating what we just said. It's a particular group of strategies with the goal of delivering better care at lower cost. Some things it does, an ACO does not do, is lower pharmaceutical costs directly, create a single payer, set insurance rate, set clinician contracts or workforce strategy, and set Medicaid or Medicare policy. They're shaped by those policies. And it does influence those things indirectly. So for the example that we did of avoiding needing the insulin because you intervened before the type 2 diabetes, but it does not do them directly. So when you do policy work, I do see a fair number of proposals come forward that ask the ACO to specifically change these different items, and that's not actually within their purview. Okay, so here's where we build the contracts. And I'm just noting that I'm making this sound like everything starts around 2016. There was about a decade of work that went into building these contracts, and we're now going to gloss over all of that, and I apologize to everyone who worked so hard for a decade. So, Ashwini, here's the chart. I'm going to build it in a couple of different phases. So we have the all-payer model. So that's what we talked about at the beginning with coordinating all the different payers. So this is signed by the federal government and the state government for coordinating Medicare and Medicaid dollars. It has targets for financial and health outcomes and process benchmarks. So a lot of these we'll see in a couple of slides around, for example, reaching scale. This is what's new about Vermont's model, the fact that we're coordinating all these payers. The ACO model itself, as I've said, is in other places. And this all-payer model contract is actually, as far as contracts go, pretty easy to read, and it is available online for the Green Mountain Care Board. So that's a contract that the state entered into with the federal government. Meanwhile, the legislature established the Green Mountain Care Board. The Green Mountain Care Board does a bunch of things. I'm only talking about the things it does with regards to an ACO. So this is not the run of things that the Green Mountain Care Board does. But they are in charge of authorizing an ACO to happen. They then review the annual performance and budget. They have direct budgetary regulatory control. And then they also track trends that are not directly controlled by the ACO, but can let them see the broader healthcare system, because the Green Mountain Care Board is also looking deeply at hospital budgets and at commercial insurance rates. So they're also tasked with setting the work of the ACO in the broader context of what's happening across Vermont's healthcare system. And I should also say that the ACO, by going in front of the Green Mountain Care Board, that also means that they are going in front of the Healthcare Advocate, the Office of the Healthcare Advocate, which is the organization that was established to represent consumers in this work, because it's highly technical, it's legal, it involves actuaries. So the idea was that even though the process around the ACO is open to the public, you do need special expertise to truly represent the public. So there's the healthcare advocate as well that is a privy to presenting to the Green Mountain Care Board in these regulatory issues. And then this is just, I won't spend time on this, but this is an example of what's in that all-payer model contract. So laying out the scale targets of that goal of getting to as much of Vermont as possible, 70% and 90%, as you see on this. Cost containment, that's way back at the beginning when I talked about how there's a particular definition of cost containment, and then setting the key health outcomes that we're looking for across the population. And that's increasing access to primary care, reducing deaths due to suicide and drug overdose. That's in there primarily because Vermont was particularly out of national norms on this, and also because we wanted to integrate mental health into the broader healthcare. And then reducing the prevalence and morbidity of chronic diseases. Those are the big three, and then there's a bunch of sub-indicators beneath those. So we have this all-payer model. We have the structure set up to have an ACO. So OneCare Vermont then first enters into a state government contract for Medicaid dollars to implement this ACO structure. And this is then the starting baseline year. So it's going to get to spoiler alert, they then sign contracts with Medicare and the commercial payers. But they start with Medicaid. And that's important because now we've started the baseline year in 2017. The timeline has started on the all-payer model contract. Something to note is that when we look at performance of the ACO now, it's looking at 2018 data. The claims need it's a 6-month run to be considered final. So this means that right now we don't actually have that much data on performance. We only have 2 data points, and one of them is this baseline year where there was very limited participation in the ACO. So we're not, in terms of knowing how the performance is going, we're not that far in yet. So that's what this is meant to emphasize. And then the final performance year in the contract is going to be 2022. Okay, so we had that starting trial with a small group with Medicaid dollars. After that, OneCare now has a set of different contracts. It has a contract with the federal government for Medicare dollars, the state government with Medicaid dollars, and then they're on their own to entice the commercial payers to also participate. And when we say all payers, we mean all payer types. So commercial payers began with Blue Cross Blue Shield, which is the largest of the commercial insurers, but it's not all of the commercial insurers. MVP, which is the next sort of big player in Vermont's commercial insurance, is now joining. And then we have an additional complication when we look at those commercial payer contracts of self-funded plans. And we've just started to get into the self-funded plans. So we're reaching scale in terms of how many different payers are signing on with OneCare to have these alternative arrangements for how we spend their money. And then that begins them on that journey towards the final goal of those global budget systems. Medicaid, which is the payer that began first, is the only one that has reached global budgets, and that's with hospitals. But we're all now on this journey moving forward. Meanwhile, providers, so like the community health centers, they also sign contracts with OneCare, and they can choose to receive payments through OneCare from any one of the different payer types or a combination. I'm not going to get into the details about why they would choose to only do one or another, and it has to do with how they manage risk and the requirements for managing the risk around this. That's like a whole different thing that is interesting in its own right, but we're not going to go down that rabbit hole. The idea is just that the ACO had a couple of goals. One was to sign on as many payers as possible to enter into this alternative system, and then they have to get providers signing up to join them. And it is posted online who's participating. And then this slide is showing that growth, right? So this is the baseline year. 2017 is the baseline year. 2018 is the year for which we currently have data. 2020 is the year that they've now signed up folks for. And you can see under programs, these are the different payers that are now participating. And you can see that growing. You can see the number of Vermonters who are participating growing. You can see the health service areas that they are serving growing significantly from 2017 as they add on new regions with providers. And then you can see changes in the amount of money that's going towards the delivery system reform and the programs that support delivery system reform, which again, we won't get into details on, but like I said, where it's not sufficient to just change the payment model, you also have to invest in changing how things happen on the ground. That's what those lower levels are showing in terms of growth of what's being supported through the ACO. And then just a quick note, because it is a point that often does get confused, which is that individual patients do not sign up for OneCare Vermont. This is, again, like many things in this, you can have an entire webinar on this as well. So patients get attributed. It's based on whether or not their insurer is participating. So if that payer has the contract with the ACO, whether their provider is participating. And it's notable to say that this is an accounting exercise. Patients aren't being denied care on whether or not they're quote unquote attributed to the ACO. Like you as someone going to a doctor's office should not experience it any differently depending on whether or not you're being attributed. What matters is how the person providing that care then gets paid. And they need to get up to a certain percentage of all of their patients being paid through these alternative payment models in order to fully say that they're operating in a value-based care environment. And the rule of thumb is about 80% to be able to be fully participatory in that. And I'll skip the new models because they're interesting, but time is running short. So just in summary, tied to the particular question of looking at integrating food into health and healthcare through this transformative work around value-based care, all-payer model, and the accountable care organization model. Healthcare reform in general, what we're trying to do as quickly as we can do it is to go towards a model that supports engaging more community groups, including those working on food as part of health. And again, the idea is we're constantly moving investments upstream in healthcare to keep people healthy. Also, if everyone is connected into a statewide network that has these non-traditional partners as well as healthcare providers, then it should be easier to share community models with promising results. Also, it is a little esoteric, the information that is available. And when you see the slide deck shared, you'll see at the end I've appended a bunch of sample slides from OneCare's presentations that tie into the themes that are discussed here. That being said, although the information is kind of hard to understand at first, it's really quite transparent. You can go online and figure out what contracts the ACO is trying to enact, what the goals and standards are, the benchmarks they need to hit, the details on spending so you know where they see investments being most important. You can get a lot of information on what's happening readily available. And also Vermont is ahead of the rest of the country in all of this work, so we can feel impressed with ourselves. There's less than good news as well. And I think for people working at that food and healthcare intersection, one of the biggest pieces of less than good news is that ACO performance, both in terms of the financial returns on that cost containment and also the quality of just how health improves, is judged on an annual basis and in a pretty tense atmosphere. Folks are very keen to see any deviation from being perfect and point that out. So a lot of work in food and health does not show results that quickly. And also, as we get into this world of the social contributors to health, it gets harder and harder to pinpoint one intervention as a single cause of health improvements. So that does not align very well with our goals. You know, on the brighter side, some approaches do have quicker results that are more easily pinpointed. That's why you see a lot of work around, for example, medically tailored meals as a entryway into getting more into this food and healthcare intersection, because you can see quicker results, for example, for the 30 days after someone's been released from the hospital, or for illnesses that are specifically tied to diet and nutrition. You can see some quicker results. Things don't have to be as fraught as they currently are around judging ACO performance. Like, that's something that we, the people, have the power to change. And also in a year, we'll be reviewing the model ahead of setting up the next contract with the federal government. So there may be some things that can be done to help resolve the timing disconnects. Another problem is that sometimes the road to being innovative means that healthcare providers are going to be more cautious because there's a lot of transition going on. There's a lot of change. There's a lot of uncertainty. A lot of that uncertainty involves big sums of money. And so that while the push is towards being in a place where we can be more innovative and we can do more with community wellness, during this transition time, there may be more of an instinct to play it safe as everything sorts itself out. Another issue is that with great responsibility comes even greater amounts of regulation. Healthcare is a whole new world of regulation. It is not considered unreasonable to have performance reports that run to hundreds and hundreds and hundreds of pages. Sometimes tying a program into that healthcare structure, if it does bring folks into healthcare style regulation, is going to be more trouble than it is worth. And then there's the idea, of course, that the overall goal is to lower the cost of care. And we're back to that point that is also on an annual basis that that's assessed. So the ACO structure is not a piggy bank for funding everything we can connect to health and healthcare. So while there's new opportunities for funding, probably there also needs to be work on how to combine different approaches with funders who have different goals, different time horizons. And you see in the Medicaid and Medicare world that that's called braided funding. And a component of that is keeping the healthcare funding with its particular goals, measurables, and regulations in its own stream, this braided with other funding sources to get towards the ultimate goal around something like food security and quality of food. So here's some links on where to get more information on this model. And my timer tells me that I'm finishing just as I had expected to. So that brings us up towards the end of the hour. And I will stop sharing now and take any questions folks have. Here I am. I know it was a lot, and like I said, I will send the slide deck to Ashwini so that it's available to look at, and it also has notes and links on it, so you can see the background information, and you can see in the appendix that I attached those sample slides from OneCare presentations, so you can see how some of those concepts are being played out on the ground and are part of the ACO performance reporting. And so that should also be helpful to folks.
Yeah, Helen, this is Ashwini. This was incredibly helpful for me at least, and I'm sure for other folks as well. And I think it speaks to the complexity of when we talk about, oh, we want food to be paid for. It's a much more complicated question than just, well, why aren't they paying? Why aren't the payers paying for it? You know, there's all of these other things that are going on in the state right now, and you know, kind of figuring out how things fit. I can, you know, I think it helps to speak to some of that complexity. So it was really helpful for me. So thank you so much.
Well, thank you to everyone for sitting through the whirlwind tour of what healthcare reform is. At least I didn't go into pharmaceutical pricing. That's something whole other level of complexity.
I also thought this was really helpful, so thank you. That's awesome.
You know, I should say the food community is not the only one that's looking at this and trying to figure out how it all fits together, right? So transportation's looking at it, housing's looking at it, early childcare is looking at it. A lot of folks working on what sort of support systems are needed for seniors and aging at home, they're looking at it. And on one hand, that sounds like, oh, there's a lot of people vying for this money. But on the other hand, because it's so complicated and because the best strategies are going to take a lot of brain power to figure out, it's actually good to have a lot of different folks working on it, because then we can figure it out together, how to make this work well. Oh, it looks like Jane is raising her hand. I've never seen that function used before. Jane, did you mean to raise your hand? Do you have a question? Oh, maybe not. She's not on mute. Oh. All right, it is almost 10. Does any questions before I stop the recording? And hopefully it did actually record and we can have the tape available.
Yeah, I know there's a lot of people. Hopefully, if it worked, I'll share that link as well, because there's parts that I think would be helpful for me to listen to one more time, you know, just to kind of hear it again, try to make sense of it. So yeah, thanks for sending that, and I'll send out the slides when I get them from Helen.
Great. Well, it's, you know, I'm happy to participate if you want help structuring some of the questions for the panel in April, just making sure that we give them the best chance to talk about helpful topics that can actually make a difference and come into play. So I look
Great.
forward to that.
Great. Well, thank you so much again.
Thank you.
And thanks to everyone that joined us today. Have a great rest of your week and a great weekend.
Thank you all.